The broadcast is now starting. All attendees are in listen-only mode.
Hello and welcome to the June 2020 Pre-Hospital Care Research Forum Education Research Journal Club podcast. The Pre-Hospital Care Research Forum is dedicated to the promotion, education, and dissemination of pre-hospital research. We believe that it is the responsibility of emergency medical professionals worldwide to build a body of evidence to examine pre-hospital emergency care. The PCRF partners with the National Association of EMS Educators to promote research literacy and advance the science of EMS educational research. Here with the PCRF Journal Club, we take a closer look at some of the latest research happening in medical education. I'm Megan Corey, and I'm here with David Page, and Dr. Bill Toon will soon be joining us, along with Paul Masasi. Today, we're going to be reviewing the study, An Event-Based Approach to Measurement, Facilitating Observational Measurement in Highly Variable Clinical Settings. This was published in Academic Emergency Medicine Education and Training in April 2020. Also joining us today is one of the study authors, Dr. Elizabeth Lassara from the Department of Human Factors and Behavioral Neurobiology at Embry-Riddle Aeronautical University in Florida. So we'll thank her for joining us. We'll introduce Dr. Lassara shortly after we do a little summary of this study. So thank you all for joining us today. Let's begin. We want to remind you, the listeners, that you can use the chat feature on your screen to type in questions and comments, and we will bring those into the conversation as we go. And if you are an educator out there, or maybe you have some experience in human factors research or a striking interest in it at least, and you have a longer comment, you can just message our organizer and we can bring you in and unmute you, and you can join the conversation as well. So a little bit of background, the purpose of emergency medical training, we all know, we're all educators out here, is ultimately to improve patient outcomes. But the education outcomes that we have a tendency to focus on primarily target student behaviors in a lab, in a classroom setting, and then sometimes in a clinical setting. But does this actually translate into enhanced clinical practice? And then ultimately, does it demonstrate an impact on patient outcomes? So these three levels of what we call translational medical education research have been applied, and we've talked about it on this podcast before. It's been applied to procedural skills like high quality CPR, where performance in a classroom or lab can then be measured in a clinical environment, a clinical practice, and then examined against impacts on patient outcomes. But there still remains a gap in evaluating the impact of educational interventions on behaviors and especially team performance in settings of complex clinical environments where there's high variability in patient presentations and conditions. And
that's totally awesome, because I needed that about 10 minutes ago.
Dave, you're unmuted. We're hearing you on your other. It's continuing. We have a real difficulty in checking or creating, reliable checklists for highly variable tasks. So the research question, or the objective of this group, was to use an event-based approach to measurement, which is often used in aviation and aeronautics, to apply to emergency medicine clinical events. So this is specifically in this case trauma resuscitations. And what was really novel about this was also that they used it to measure team level performance. So just briefly the methods, and then we'll pull in the authors here. They used a 4-step approach to create, and you can see this actually. We'll see if I can advance the slide here. If you can see the slide here, this 4-based event-based approach to measurement it's a 4-step approach that they use, though, to create emergency department trauma resuscitation patient care measures. And these were measures that some of these were universal events that could be applied to all trauma resuscitations, and we would be familiar with some of these in EMS, anything that relates to the ABCDE, and then conditional events or items, things that depend upon the patient's condition. And then they applied this to 360 recorded videos of trauma resuscitations at a level 1 trauma center, and it was Harborview, University of Washington Trauma Center. They had trained raters who watched these videos several times and rated these items that they had previously developed. And then a subset of those, 50 of those cases were used specifically to measure the inter-rater reliability of the raters. So this was to measure the Cohen's kappa, it's called, which is an inter-rater reliability measure of qualitative research like this. So let me just take the time now to bring in our author. So we have Dr. Elizabeth Lassara. Dr. Lassara, welcome and thank you for, first of all, congratulations on your research, and thank you for joining us.
Thank you for having me.
Yeah, can you tell us a little bit, just about yourself and your work, and then how you came to do this specific piece of work?
Sure. So I first and foremost should say that I am not a clinician and I have no medical or clinical expertise, but that is the beauty of multidisciplinary teams and collaborations. You can join forces and everyone has different perspectives and strengths. So I am a human factors psychologist, and in case there are some folks out there who have not heard of human factors psychology, a quick spiel is that it is the study of humans and systems, and those systems can be something as simple as the ergonomics of your chair or your keyboard or your desk that many of you are probably facing at the moment now, working from home, coming up with impromptu workstations. You're noticing all the human factors of that workstation, or it can be something as complex as the cockpit of an aircraft, or even a hospital, or out in the field in an EMS agency, or in the back of a bus. So human factors spans a variety of different domains and applications, and it focuses on understanding those systems to improve things like safety, satisfaction, productivity, efficiency, etc. So that is my background. And I have a particular emphasis in training and teamwork and performance measurement. So I was brought on to this paper and this effort, not for the data collection piece or even the data coding piece, but for my previous work that was done approximately 10 years prior that looked at event-based training techniques for emergency medicine. However, those techniques are applicable to any domain for that matter. And so we applied those same principles, those same methodologies to now not just training, but specifically to measurement. And typically those trainings occurred in the simulation setting, that methodology, that approach. And so another difference of this paper was looking at how you can use that approach to study live clinical performance as opposed to performance in a simulated setting. So I will stop there and let some others jump in.
That is very cool. The kind of gift here too is that trauma resuscitation is the perfect selection because they're videotaped and audio taped, and so you can, see, and you even may get some of the pre-hospital information if they during the video and audio tape they bring in the pre-hospital radio call-in. And then as the patient enters the room, you have the prep, you have everything really all the way through to when the patient leaves the trauma room. So it's actually that was a good selection. Was that who decided on the selection of which type of patient to pick in this, or which type of event to look at?
That would have been Dr. Fernandez. So Dr. Fernandez is a clinician, and that is her area of expertise and her focus.
Yeah, it was a really good choice. I'm trying to think of any other situation where you could have the evidence right there and videotaped, which means you could return to it over and over again.
Maybe OR environments often videotape, not all obviously, but the OR does have that as well.
Yeah, you can see where things that are either very much follow either a checklist or are procedural are areas where maybe you see some of this translational research because you can follow a procedure or something that's recorded. But I like this choice because, like as you said, it's highly variable. It depends on your decision, depends upon what the patient has done or said before it, which is something that educators have always struggled with. When we're trying to measure student behaviors, and at whether it's in the skills lab or whether it's their knowledge base in the classroom, or then when they go into a clinical setting, we all know that, and there's a lot of educators out there, we all know the minute we hit the clinical setting, we have a number of factors there. We've got reliability of the raters that are, preceptors that are the students are being placed with, are we giving them, are we all in agreement on the different types of measures? And then the measures tend to be, are they subjective? Are they, it's a real struggle trying to factor in what brings that kind of success. And then that's just in the initial training I'm thinking of, and then we take it out into the field as well. But what about clinical practice, changes? And that's the next level of translation. And then, of course, the last would be the patient outcomes. So yeah, this is a real educator struggle here.
Yeah, I think one of the beauties of this technique is that, or this approach rather, is that it minimizes subjectivity for those preceptors and those observers by having these a priori commonplace events or triggers that you can often expect to see behaviors exhibited, and then typically it's presented in a checklist form. So it reduces that workload of those raters by simply looking for presence and absence of specific behaviors.
And that's another attractive thing, because it takes the kind of opinion out
Correct.
of the out of the equation. So we have Paul Masasi. I'm not sure if Paul is unmuted yet, but the minute you are, Paul, if you want to interject, we'd like to bring you in, because I know this was this human factors in emergency medicine and in EMS is part of your doctoral research. So, which is, fantastic. I know we were having a little bit of trouble with audio, but feel free to interrupt the minute we've got your audio in. In the meantime, can you just walk me through this evidence-based, this event-based approach?
Sure.
Yeah, just walk me through it. I mean, it's right in front of me, but we've got arrows going back and forth, and I'd like to understand a little bit better.
Yeah, no problem. And I actually might take a step back even and give a more holistic picture.
Sure.
So one of the common themes that we often see from a training, education, and psychometric standpoint is that oftentimes people select cases for performance or training or education simply because they're particularly neat or interesting or frequent or critical, etc., as opposed to focusing on particular learning objectives or particular knowledge, skills, and attitudes that they're hoping individuals will portray. So one of the benefits of this approach for measurement and the similar approach, event-based approach to training, is that you rely on those learning objectives and those knowledge, skills, and attitudes, and then you consider the context that would be relevant to exhibit those things. For example, if you wanted to train or assess something like teamwork, communication, which is one of my areas, then you don't necessarily have to pick a resuscitation. It may be a good context because there is a great deal of interdependence and communication and teamwork exhibited, but you don't necessarily have to pick that. So the resuscitation becomes your context as opposed to your objective. Certainly, it could be your objective depending upon what it is you're trying to aim and improve. So starting with those objectives and the knowledge, skills, and attitudes is a critical piece, because then it can guide you to determine what events and what triggers can be embedded within those scenarios and the performance episodes that would elicit the desired behaviors that we're looking for. So in a training context, as an example, if you're wanting to focus on something like speaking up or voicing concerns, then you may have some kind of confederate or some other individual, some instance with which information is incorrect or information is withheld or not communicated or disseminated yet, to give the learner an opportunity, or that individual, that performance, an opportunity to exhibit those behaviors. So because you know those triggers and you have those events defined, then you have an expectation for the types of behaviors that you expect to see and will manifest in itself. So then based upon those, you can organize your metrics in such an order that would be perhaps chronological. And as I mentioned before, they're oftentimes dichotomous. So they're typically presence and absence to reduce any subjectivity. And then also you can get as granular as you want. So if you know that you're expecting a performance to exhibit a three-pronged approach, or again, I'm not a clinician, but let's say you're looking for a head tilt, maybe a hand placement or equipment of some sort, then you can get as granular such that you can look for all of those things as opposed to being more global and then missing kind of those key details.
Well, this is so timely because we're in an environment right now of simulation-based learning, whether it's virtual simulation or in the face-to-face setting. And one of the things in simulation is to be able to create, and actually in the virtual simulation, it sounds a lot like case logic, that you use in gaming, where you have an action, effect, a timer, and a check, and you can actually branch off into these effect chains. It sounds a lot like that, but you can actually, it's the reason I find it attractive is Dave always, we're always talking about developing simulation where you can embed your skill into the simulation rather than have these stations. It's very old-fashioned. You have these stations where people walk up and do this very robotic kind of skill, like endotracheal intubation.
Terrible. Yeah.
But think about it. If you can embed it into the simulation, and you have these sort of triggers and key events that are defined that branch off about that specific procedural skill. And I guess in the next slide, there's more of I think an image of that of a specific. If I can get to it. Yeah. There's more of a specific example of it.
I love this. I love this in so many ways. I think I really want the listeners to pick up on this concept of a dichotomous variable, a yes, no, positive, negative. Did it occur? Did it not occur? That tends to increase validity and reliability of the evaluation, because the raters need to be able to say, look, it happened or it didn't happen, versus a love affair that EMS has with, on a scale from 0 to 5 or 0 to 10, do you feel like this objective was met? And so the cognitive load on the evaluator is such that you're going, well, they kind of did deal with scene safety, but they kind of didn't do it the way I wanted them to. And we tried to do this with the National Registry out of hospital scenario. In the video, we show a dog that starts to bark. And so you have to recognize the dog is barking and recognize it as either a threat or not. And so you ask for more information. And as long as you recognized it, asked for more information, tried to reconcile it, you've met the objective, right? So this confederate or event-based piece inside simulation that says, were you situationally aware, tries to get at some of those aviation-like key indicators of crew resource management, culture of safety. Are you really participating as a team, that a lot of educators, at least in the EMS world, don't feel like they can measure. How do you measure situational awareness? Well, you give them a situation. If they are aware of it, then they actually recognized it and are going to either mitigate it or not. So I really like what Dr. Lassara is saying, and I'm anxious to hear Paul Masasi's take on it, because he, of course, has done a deep dive on this piece of EMS embracing this culture of safety and looking at events and trying to measure whether or not, some event, especially in real life, was actually handled correctly.
Paul, are you on?
That was a little egging on of Paul. He unmuted himself. He's ready. Oh, but we can't hear him. Keep going, Megan.
Oh, that's a bummer. Well, like I said, Paul, just interrupt whenever you're in here, because I'm really curious about this, about how this could apply. I mean, not more curious. I have so many ideas kind of rolling around my head, and I'm sure a number of people out there that are listening too, how can we apply this? Dave, where are we on this? So just, you mentioned it. You said you were working with National Registry on things like this, these.
Well, it got ruled out. It, in fact, is part of the current out-of-hospital scenario that there is an event I was particularly worried about this constant, sort of recitation that we have around simulation, where you don't really have to have situational awareness. You just recite the algorithm or recite the list of things you should be checking, but you're not really communicating with a team. You're just evaluated by yourself. So this was an attempt, and we only know how good we got until we actually go measure and see if we moved the needle on our ability to both simulate and measure teamwork and interactions between the team. But the introduction of an event or a change, or some people call it a curveball, or something that causes you to have to make an adjustment to your care, or it causes an action, which is, I think, what Dr. Lassara is trying to say is you need the action in order to confirm that this was done. If all we did with situational awareness was try and pretend that we thought we heard somebody's brain be aware, we'll never know if they're aware of it or not. Yeah. But if inside the simulation, then there's some trigger that causes an observable behavior, which I really appreciate in the paper.
Yes.
Then the observable behavior can then be said to be accomplished or not. And I want to bring this into actual care preceptors and the concept of measuring performance in the field, because the article is really about clinical events that are in real life, and these observable clinical triggers need to be identifiable, and again, care needs to be evidence-based. I like this clustering idea, so that we can at some point say the quality of what we saw met the mustard. And with these checklists, which are really part of all of our future in terms of culture of safety, in terms of being able to make evidence-based decisions and have either job aids or some terminology, whatever you want to call it, that says I can refer to something that is real time, that helps me go in one direction or another. And we in EMS don't have experience creating these. So this is the beginning of, I think, Paul can correct us if I'm wrong, but this is the beginning of how aviation began to craft checklists that were, real time, critical. We're about to crash the plane. I need to look and see what the 3 things are that are at the top of this list, versus our current, sample OPQRST, LMNOP, which is some memorization aids to list things that don't apply to this event.
Hey, Dave, can you hear me?
Yes, yes.
Oh my God, I got it. Okay.
Yay.
Well, so I apologize for the delay, but I did want to mention I certainly appreciate this research, because it certainly applies to us, and I think this is one of the areas that is, as Dr. Lassara alluded to, is ready to be applied in our domain, and I'm glad you guys have picked up on that. That this can be done in a way that is reliable and valid and achieves what we're trying to achieve without, I think, as you were mentioning, just having these static stations do the skill, etc. That if we're willing to learn from human factors, simulation science as well, and how to do it well, that we don't have to focus in on, did they make 3 complete concentric swirls with the alcohol prep pad before they stuck the IV in the patient's arm or the mannequin's arm. There's many more things that we can learn to tabulate, if you will, and verify if we look at research like this that can guide us in doing so.
I couldn't agree with you more. Tangled tubing, that's the one step in the IV skill.
And I think Dave brought up a really great point, which is that this approach is heavily tied, inherently tied to observation-based measurement. So another downfall that sometimes I've come across is that folks want to include metrics and assessments for things like understanding. And those types of things aren't necessarily observable. How do you observe understanding? Or even something as listening. How do you observe listening? I'm an educator in the university environment. I can tell you that most of my students are looking at me. Does that mean they're listening to me? I don't know.
Love it.
Love it, yeah.
You need to make sure that you need to hear things or see things with, even sometimes we'll get attitudinal assessments. So this interaction was, happy or polite. That still, in my opinion, isn't specific enough or observable enough. What do you need to see to know that you are exhibiting politeness? So that's an excellent point that Dave made earlier about this need for it being observable.
And I think it's achievable. What I think EMS providers are at a loss for is, EMS educators are at a loss for, is exactly how to achieve that. And we saw a study done in Rochester more than a decade ago where empathy was measured, and introducing yourself using the patient's name, creating trust, but very observable behaviors. You introduced yourself, you used the patient's name, you attended to their comfort. These are observable behaviors that can then say, okay, that created an empathetic environment, and then ask the patient, did you feel like you trusted this provider? And so these are ways in which we can begin to get at things that appear to be unmeasurable, but are in fact affective domain measurements. What I loved about the paper and the tool is it covers a lot more than that, because it's actually measuring care as well. Go ahead, Paul. Sorry.
I was just going to say that some of Dr. Rona Flynn's work in Great Britain, looking at crew resource management, if you will, in the operating room, there's a lot of very good, valid tools and reliable tools out there that can demonstrate and guide us in understanding how we can quantify these things. Did this operating room team do crew resource management well? And they've even quantified it to the extent that they have measured the extent of harm created if a team doesn't do it well. So they can actually make the argument, well, that if you're not going to do this well, here's how much risk you're adding to this patient's procedure. So I think investigating these tools and translating them into our context are important. That's why, and it's very useful. It's very pragmatic, and one of the reasons that I obviously feel very strongly about incorporating human factor science into the work that we do. So it's available. It's out there. We just need to understand how to use it.
Yeah, and I think this is a good segue into coming back to that study design where it's really clear here that the steps are outlined in kind of a 1, 2, 3. Incorporate evidence-based practice, define events. Step 3, define the event trigger, and then test and refine the measure. I think those sorts of very clear, this is the way you're going to be able to make this checklist be useful for that event, is quite helpful. And I think we're going to need to be open to learning from other professions about, in real time, how to lay this out so that either an evaluator or a person themselves can follow the checklist without getting bogged down on too many. We have a tendency to put paragraphs, entire diatribes there of philosophy into a decision-making tool or an evaluation tool, and we have to clean it up so that we can clearly not have a cognitive overload moment when we're trying to concentrate on this is what's supposed to happen. I'm sure I've told the story many times, but I was in a cockpit of a 747 with a pilot who Dick Blanchett, who's the paramedic, who was showing me how it is that his checklists in a cockpit kind of work even for someone who doesn't know anything about it. And my windshield cracks, I look it up, it says drop to 10,000 feet. It doesn't say why, how, or et cetera. It's a very pragmatic approach, as Paul said.
Staying on this topic of the raters, and what you're kind of getting at is, let's say you ran simulation in your classroom and you were running summative simulations. The question is, if you had these events and triggers and metrics all set out ahead of time, and you videotaped these simulations, could you then have a non-medical person rate them? And that kind of brings me to a question about the raters here. So I'm wondering, Dr. Lassara, if you can tell me about how the raters were selected and tell me a little bit about them, because that was something that stood out to me. Was these were not trauma surgeons.
Unfortunately, in this particular project, I actually cannot answer that. That would be a question for Dr. Fernandez. However, I can tell you in other efforts, we have used non-clinicians to rate performance. And so it is possible. You just have to have a great deal of specificity and a great deal of care and time dedicated to training those raters such that they are aware of what exactly is the appropriate angle for a tool, or what is the correct touch or pressure or speed, whatever the case may be. So it's certainly possible to have non-clinicians rating these things. There's obviously advantages and disadvantages, right? So the disadvantage is that perhaps it takes more time for those individuals to get up the sufficient knowledge. Conversely, they might be more cost effective, or they might have more time. Many of the clinical experts, especially the world-renowned ones, they don't necessarily have time to be viewing hours and hours of video footage. So there's advantages and disadvantages to having different types of raters, and it really just depends upon your resources and your logistics.
Oh, that's a research study in itself, right? Having raters, coders, or raters that are medical versus
Megan, when we get to the data coding, which of course in real time, your instrument has already been validated and proven, and so you don't need to do this post-event analysis. You're really trying to get the tools for people to be able to use in the real world. But it says it's worded that just the wording is I think very telling. 2 consecutive low blood pressures are the trigger, and it should the team initiates a blood transfusion. And so when you have that kind of a specificity, then someone who's not a subject matter expert can look and say, were there 2 blood pressures? Did they start a blood transfusion? And to me, those are very simple, key terms. I've seen and battled with evaluation sheets that have positives and negatives in them. So you're trying to see the absence of something while you're trying to see the existence of something, and that in and of itself, just the language and the way that our brain is trying to capture, was this done based on the fact that these 2 things were done, really cause us to have just not a good, I guess, reliability in the evaluation.
I did want to ask Dr. Lassara a question when it comes to raters. To what degree, maybe in your research or experience, has the use of subject matter experts improperly imported some information into their observations? So
absolutely.
where they would think, well, I know what they were thinking and that's why they did this, where there's no real demonstration of what you're after.
And that's a great point, and I'm glad you brought that up, Paul, that that's another consideration. I don't want to say disadvantage or advantage, because it really, quite frankly, is a consideration depending upon your goals and resources, but that experts obviously have biases and automization, right? So let's think about a really simple example of tying your shoe. If you were to tie your shoe, all of us are expert shoe tiers, and so we can tie our shoes very quickly. Now, if you were to ask someone to think aloud and describe how to tie a shoe while they're tying a shoe, then they start to do that activity differently. So applying this now to this domain and this experience, raters then are able to, or experts, excuse me, are able to automatize some things. And so you're right, they might introduce their own expectations or their own intent or their own inferences with things because they have that knowledge base, versus a novice doesn't. A novice is not able to make any of those inferences because they simply lack the ability to do so, which again, as I mentioned, is not necessarily advantageous or disadvantageous. It just depends upon the situation and is a consideration to keep in mind.
Well, that's a consideration too when you're developing, right? So when you're developing the evidence-based, well, I guess not the evidence-based criteria, but the events and the triggers and the metrics as well, right? I mean, you need the subject matter experts because but I guess if you use ATLS like they did here, you used a combination of subject matter expert and evidence-based guidelines that are already out there to develop, but then it's to observe, to measure and observe and be a coder or rater that we're talking about here. That I guess I just want to point out that when you asked that question, Paul, there wasn't a second of hesitation on Dr. Lassara's answer that of the problems that result from using experts, or that can result from using experts versus someone who's not maybe a clinical expert.
No, I should be very clear though. I am wholeheartedly an advocate for having clinical experts in addition to training and performance experts. This is not done in isolation or in a vacuum. As someone who's trained on the science side of things, I am not aware of the clinical algorithms, nor do I expect to know those clinical algorithms. So you certainly need these collaborations between the individuals who have their respective expertise.
Absolutely. I was just going to mention that it's often harder for those clinical experts or the subject matter experts to actually articulate how they know something. So I think it's important to have someone. It's important to have a human factor scientist as a part of your team to probe some of that knowledge and to identify, help the subject matter experts identify what cues are they picking up on, how they know, so to speak.
I think that example of tying your shoe is such a perfect one. I think because we all do it so automatically, and now we're all going to slow down and go find somebody, a kid who doesn't know how to tie their shoe. See if we can slow it down and explain it. And and everyone probably has a little nuance. Well, I do 2 loops and then I wrap them around, or I do the square knot and the So
well, and every human factors 101 class, they have you do a task analysis of making a peanut butter and jelly sandwich, and then you write it out, and then you expect someone to follow it, and that person gets to play, the as dumb as they can, and they're going to follow your instructions to the letter, and it doesn't always work out very well.
Yeah,
I think the person that followed my instructions ended up putting all the peanut butter and jelly on the crust on the outside edges.
Oftentimes what happens, using Paul's example, is that we'll say something such as put the peanut butter on the bread, but technically that's not correct. That would make you put the jar of the peanut butter on the bread. So, as opposed to put the knife in and spread the, yeah.
Well, I want to point out too that in the section on data coding, there is a statement, and I have a bunch of little stars and a statement that says, wish we did this with EMS educators and preceptors. The statement that all coders trained until they reached a Cohen's kappa of greater than 0.75 across a range of performance episodes.
Yes,
that
absolutely.
varied. Yeah, and that just really struck me. Bill Toon has texted me saying that we should use old retired paramedics. I'm sure he's being tongue-in-cheek because he said old retired paramedics are perfect. They have no opinion. Yeah, I think that was definitely a little sarcasm there. So, Dave, what did you think about that? Did that stand out to you? The coders trained until they reached an actual, inter-rater reliability level?
I love it. Very consistent.
Yes.
We saw early on, Scott Bourne and Baxter Larman did some work around the ability for two people to look and see, for example, rate a Glasgow coma scale, or you just even agree that that's the right APGAR. That. But if raters don't get a chance to run through an example, then it doesn't work. And I think we quickly forget that in EMS. We can easily create, whether it's a scenario or actually film real performance, and just run either preceptors or lab instructors through a process that says, when we're looking for this trigger and we mean this, do we all agree that that met mustard? And that kind of calibrates everybody. I think that you get much better inter-rater reliability at that point. There were many studies done maybe almost 20 years ago about how the inter-rater reliability on even recited National Registry style stations that were set up for a skill to be just kind of performed in isolation were having quite low inter-rater reliability, because one evaluator might think, well, I don't think you put the cervical collar on the way that I would have put it on, and you didn't measure it the way I measure it. So without having kind of a calibration session before you begin the rating, that gets to be problematic. And I do think that's part of why the COA is requiring preceptor training. That's why we want to train our lab instructors to look for things, but also give them the right instruments that make it so that they can succeed.
I'm glad you brought up preceptor training, because I think that's really the area that at least I'm sure it's regional as well. This varies, region by region, but that's an area of great variability, and not a whole lot of standardized training, and the standardized training tends to center around adult learning theory and how to provide effective feedback, which is very valuable. But what about the measurement? And I think that's where preceptors will tell you they struggle, is what is this? What is a 1, 2, and a 3, or a, even if you provide a rubric for it, it's, it isn't based upon, like you said, directly observable yes or no, based upon a decision, a clinical decision that we've all agreed upon. And therefore there's an introduction of bias in there about how things should be performed and whether or not a student is progressing, and that's probably why that's the most problematic area, I think, in paramedic education, at least around here. And I'm in California, where there's the heavy reliance on the opinion of the preceptor as to whether or not the student is achieving competency, rather than having these standardized, was it done or not, in response to whatever trigger we've defined. So, and I'm not sure how it is in other areas, but this is the first thing I thought of in here. It's not just the educators that are teaching in the classroom and lab, but also in the clinical setting, and in particular in the capstone. I mean, it's the capstone setting, right? It's the time when the student is taking everything out into the field. So I think that's an interesting application there. See if we can apply these measures to our field evaluations.
And I think that a priori agreement is really a key piece of this. To go back to an example that Dave used earlier, mentioning the empathy, he mentioned a few specific behaviors that could potentially be manifestations of empathy, such as using the patient's name, introducing yourself,
Yes.
things like that. So obviously, each one of those could be a manifestation of empathy, or both of those in combination could be the manifestation of empathy. And whether or not you have this benchmark, this, as to use this phrase, cuts the mustard of needs to be both or one or the other or a specific one, doesn't necessarily matter as long as you have agreement a priori before you get to the performance episode, that we all are in agreement that we need to see the provider using the patient's name and the provider needs to introduce him herself. And that's what is considered presence versus having one of those behaviors be exhibited, and just simply having one of those, we're determining that as the behavior being present.
Yeah, and I think when it comes to the skills and simulations too, Dave, looking at the table that's in the supplement, and I've got it up on the slides if those of you can see the slides, this is one of the tables that's in the supplemental material that shows the items, the universal items that were decided, look, this should be done on everybody. And if you notice, this should be very familiar to us as well. In EMS, it's basically the ABCDE. So, and you can see that these are all the trigger is NA because this is done for every patient. This is our linear kind of approach to assessing a critical patient, a critical trauma patient in this case. And then you have the conditional items below that were defined and again evaluated for subject matter by subject matter experts and standards for evidence-based practices, and then defining the events. Here you can see the event, the trigger, the behavior that we expect to see, and that's where the observer can see that if it really is an if then, isn't it? Am I right here, Dr. Lassara?
Yes.
It's kind of like
Yep.
an if this. It really does remind me of how you build a gaming program or a simulation game where it's action.
Should, as it's aptly named, trigger a specific behavior to be manifested. So the trigger should solicit a particular behavior that you're hoping to see and assess.
And I noticed that there's no timer on here though too. So timer might be something that, I know they do that in some of the online virtual simulation stuff, is they add a timer. So if you do the ACLS heart code or whatever, there's a timer in embedded, I believe, or in some of the other ones where if you don't do something within a particular period of time, then it triggers another change. So when you build it into the program, so that's also something maybe that would be built in if something isn't done within a particular, so maybe it's done, but it's not done within a particular time period.
Right.
That might be built in.
Or another consideration sometimes you'll see is that if something was done, but it needed an additional prompt to do it. So maybe a confederate says, are there any more labs you would like to see, or are there any more tests that you would like to order, those kinds of things. So that performance, that individual has to be prompted to then elicit those behaviors.
I think prompting is really a fascinating piece to this. There were several folks that tried to create a rating scale based on prompting, which we adopted for the registry in-field evaluation tools, and it's brilliant because it's simple. If the student is not prompted to perform an action, then they initiated the action themselves, and they didn't need reminding or didn't need some sort of stimulation that said, don't you want to put oxygen on, anything else you want to do? And it really is kind of an automaticity or an independence of the leader to say this needed to happen. But in the advent of culture of safety, we want teams to prompt each other if there's something missing. So we want to have teams that say, team leader, I see this problem. Here's a solution to correct it. Do you agree? And this causes a conflict between this concept of the leader having to think of it all by themselves. And it shifts our focus from a leader that's supposed to know it all, do it all, and be able to do it by themselves, to a leader who's inciting or communicating with their team and isn't necessarily competent at knowing everything themselves, but is competent at making sure that the team is feeding them the information they need or contributing to the solution. And I think both are important. We test cognitive ability in a written exam. We can test the ability for the leader to do things on their own based on certain prompts that are embedded in the scenario or that are seen in the field. But this concept of leadership by committee, or not committee, because that always gets a bad connotation. The concept of receiving a suggestion from your teammates, evaluating it and incorporating it, implementing it, is leadership. And it's something we don't currently value in our evaluative processes. We don't have a way to say, we need to see that. It just kind of either happens or doesn't. And team members are told, don't contribute, because then you'll destroy the evaluation of the leader who's supposed to be doing this on their own. So we need to advance ourselves a little bit in that concept of what and how this prompting affects the final score of a competency measurement, of a evaluative. Did they do it or did they not? Did they lead or did they not? I'm curious to see if Dr. Lassara has any insights for us.
No, I think this approach is great for exactly that, because you can purposefully have, especially when it comes to training, but certainly in the clinical environment as well. But in training, you can purposefully have someone who is deemed the de facto leader not exhibit certain behaviors or not communicate specific information in hopes that you are requiring other individuals in the room to solicit that information or to solicit those behaviors. So you can give them and embed opportunities for them to exhibit those behaviors purposefully, and then assess on to the extent that they do exhibit those behaviors. And we actually did that in handoffs many years ago, where we had the sender of a handoff purposefully not include some information with the hopes that the receiver would then solicit that information, because it shouldn't just be this data dump. It should be an interactive information exchange where the recipient is also a willing and participatory, engaged individual in that event. And so I'm good for that as well.
Yeah, and I love the control we have when we're purposeful about our simulations, when we've really thought through what it is we're testing, and then we create the scenario that tests it. I'm curious to know, in real-time events, essentially preceptors are choosing in real time to either prompt or not, or insert or not, and so this handoff is a great example, because the preceptor might know there's a piece of information missing, either that the student was supposed to solicit or give, and they have to kind of have a hesitation before they, in their reasoning, the preceptor's moving a lot quicker in their brain and says, well, this is missing, they better say it quick, or they better ask it quick, or they better do it quickly. And that internal clock varies greatly between the preceptors. So some of the things that Bruce Nippon did around prompting actually forced the preceptors to wait 30 seconds to create the prompt, on the concept that 30 seconds of anything won't injure somebody. You wait for the student to be able to kind of catch up a little bit. But gosh, in real time, it's hard to get the preceptors to back off and or the expert to back off to let the novice really have the time to process and say, I think we missed this.
Yeah, that's a great point, that you really want to standardize between your raters of the extent of the prompting. You know, if you get one individual who is eager with their prompting, then that individual who is performing those behaviors may get a totally different score than another individual who has another rater who is not so eager to prompt. And those behaviors and that performance may be a reflection of that individual. However, it may also be a reflection, or at least a partial reflection, of the eagerness of the prompter. So you want to be sure that that is standardized between those different raters.
Well, that's tricky. And Dave, like you said, everything that we do, everything that we've built, kind of the structure of paramedic education is, I don't know, it's not fulfilling what we really want, which again, the thing that's beautiful about this study is the emphasis on the patient outcomes, on the evidence-based practice that we know would result in better patient outcomes. So if every one of our evaluations in school thought about, you know, which element of this simulation is founded in evidence, you know, that these practices will improve outcomes, then, you know, that would be, that's one way of kind of revisiting some of our simulations and some of our skills as well. But also, you know, when we think about the progression and even looking at, you know, even something like Appendix G, which is our educational piece of that we use to assess minimum competencies. It's a matrix of our minimum competencies in the initial paramedic education. There's a suggestion that we progress, you know, in a certain point, and it ends with this capstone experience. But the capstone experience, the student leaves the physical environment of the program, goes out into an ambulance. They don't leave with a team, they leave by themselves. So it's, you know, that they enter an environment where they're evaluated on their own in a team environment. But again, we did a podcast once on team familiarity and patient outcomes. If you remember that, Dave, do you remember that one? I think it was a Canadian study. I can't remember, but it was, or Australian, on team familiarity and improving patient outcomes. And
yes.
And that first thing I thought of was, well, this makes no sense. Then we tell students to become very, you know, good team members and team leaders during school, and they practice and they're together. And then in the end, we tell them, now you're going to go out by yourself and you're going to lead the team with a bunch of people who are told to put their hands in their pockets until you tell them what to do. And it just doesn't, that's not founded in good evidence. So,
well, and it's fascinating to equate that with pilots who, one would think you fly with the same partner, you know, pilots work together in pairs, and but in fact they also go out and have to swap partners every flight. So they're you know, honestly not paired permanently, and there's a difference in novice versus expert and skill ability, but planes aren't falling out of the sky. So somewhere along the way, when these pilots are being trained, they're being trained to standardize some of those processes so that there's less variability if they're, you know, if you're working with someone you don't know. Mm-hmm. And I think that's the problem we're having, at least in our world, is we don't really understand those processes. We haven't embraced that culture of safety, so we can't quite get there. Yeah. I don't know. I think we need help.
I think so too. This final little table here is just showing you the variability that we're talking about. So this is this study was done with a you know, 360 trauma resuscitations. Actually turned out to be 342, and you can see the variability in the different types of patients. Again, it's if you're reading your research, it's always great to go to the supplemental material so you can see the specifics of some of the information that they're referencing. We're actually at the top of the hour. So Dr. Lassara, any final words for us and EMS, how we can get there?
No, I think that EMS has made many great strides and they will continue to do so. There's a culture that I've certainly noticed for the years of working with these individuals of betterment and wanting to do better and very patient focused. So as a potential patient, that makes me feel good.
Oh, that's wonderful. Thank you and congratulations on your tremendous research. Paul, do you have any, are you still around on the line here on audio?
No, I appreciate the opportunity to participate. I'm glad Dr. Lassara was able to join to share some of her expertise. With EMS, we've been doing simulation for some time, but I think we've got some work to do in terms of creating processes and procedures to make our assessments more reliable and valid.
That's great, thank you. And we look forward to more of your research in EMS. Dave, any final thoughts?
I just want to thank the authors and love that we were able to have this discussion because of the work that you did. And we do dare to care. Sometimes we burn out quite a bit. But it is, it's impressive. We have listeners here from all over the world. Dr. Convacar is with us all the way from the Philippines. She had to jump out and go take care of a patient with COVID, but she is COVID free. So we are safe virtually. I think we must just learn from each other and be humble in that we don't have all the answers. So really appreciate the contribution.
Wonderful. So from the Pre-Hospital Care Research Forum and National Association of EMS Educators and FISDAP, thank you all for joining us. Don't forget, we're coming back. We're going to be twice in July. Pre-Hospital Care Research Forum Education Research Podcast is 1 week earlier than usual, so it will be Friday, July 17th. 10 a.m. Pacific, noon Central Time. And that same week, we're having 2 podcasts in 1 week, is the clinical podcast, Monday, July 13th. 10 a.m. Pacific, noon Central. If you want to present an upcoming article, please email David Page at dpage@emsed.net. Thank you and see you next time.